This is Dr. Galen Henderson of the Brigham and Women's Hospital, Department of Neurology, Division of Neurocritical Care. I'm here to talk with you this afternoon regarding seizures and status epilepticus. I have no industry relationships to disclose. This is the outline. Over the next 40 minutes or so, I'll review issues of seizures, epilepsy, emphasizing the inpatient setting, seizure precipitants, treatment options, and reviewing status. So, definitions. Seizures are clinical manifestations of an abnormal and excessive excitation of population of neurons. When we look at an EEG, or let's say an EKG, we want things to be rather random. When things become synchronized on the EEG, that is a radiographic seizure. Epilepsy is just a tendency towards a recurrent seizure, unprovoked by systemic or neurological insults. And acute symptomatic seizure is a seizure resulting from systemic or neurological insults. In regards to the epidemiology, this is something that's very common in regards to seizures ranging from 50,000 to 200,000 per year. A third of these patients have known epilepsy, a third are new epilepsy patients, and a third are from acute neurological injuries or disturbances. We see this disease in two populations more, in young people, in kids, and older patients. Seizure classification include partial or focal seizures. So it can be simple seizures that where the consciousness is preserved. People can still be awake, alert, talking to you, and have simple seizures. Complex seizures is when consciousness is impaired or lost, and some of them can have one type or the other, and then it can secondarily generalize to the entire brain. Or they can present with generalized seizures. The one that gets the most attention is the tonic-clonic grand mal seizure, but it could also be absence, myoclonic, tonic, or even atonic seizures. With the drug choices, there are many drug choices, and we try to determine which one may be the best for this particular patient. So we are aware of their spectrum of actions and also how to load these patients and the pharmacokinetic of all of these drugs. So it does matter what concomitant diseases that they have, and we have to take into effect the efficacy, side effect profile, and cost. Some of the seizure precipitants include metabolic disorders such as hypoglycemia, hyponatremia, hypocalcemia, and so on, you see here listed, or drug intoxication, drug withdrawal, or acute neurological insults. Drug intoxication, I have a few listed here, which can also include antibiotics such as fluoroquinolones, antihistamines, immunosuppressants, stimulants. Patients may have drug withdrawal such as ethanol or alcohol withdrawal or other anti-epileptic drug withdrawal. And acute neurological insults such as stroke, trauma, CNS infection, anoxic brain injury, or neurosurgical procedures. The differential in regards to if a patient presents with a seizure or not, we should think of what other things instead of a seizure it could be. Yes, it could be a seizure, but it also could be syncope, convulsive syncope. And let me give you an example. You can go online and look at YouTube and find video clips of patients with convulsive syncope. And so in this video that you'll see, which is a German video, the patients are all hooked up with EEG monitoring. They have the patients squat down, to the floor, hyperventilate, and then stand up. And when these patients stand up, they syncopize, and in their syncopation, They have tonic posturing, convulsive-like movements, things that we would put in the category of convulsive seizures. And they can look like traditional seizures, but are not electrographic seizures. Some patients can have migraines presenting that looks like seizures, or TIAs that look like seizures. Here's a list of choices that we have in regards to some of the anticonvulsants that we can use. As far as what is a seizure, how long is it? Basically, if it's greater than 5 minutes and the patient has not regained consciousness in between spells, that is considered status. Status can, any kind of seizure can present in status. You can have convulsive status or non-convulsive status. Partial status, generalized status. Main types of generalized convulsive status epilepticus, you see here, or non-convulsive status epilepticus. The downside of this overall entity is that, typically if you were to see a seizure occur, this is one of the most frightening things you actually would ever have to see, I think, in man. But the systemic dangers include cardiovascular events, because they can become quite tachycardic and rule in for myocardial infarction. They can have respiratory issues, aspiration-related issues. They can have tissue breakdown or rhabdomyolysis and affect kidney function, and other things that can be seen after 30 to 60 minutes of seizures. With the neurological insult, we can easily see cerebral edema, neuronal death. There's higher morbidity among survivors of prolonged status epilepticus for 30 to 60 minutes, and it can be quite dangerous. So as far as etiology of status, here are some of the common things that we think about as far as causes. Low levels of anticonvulsants, having had a stroke or alcohol withdrawal, or idiopathic. Prognosis of status. It seems that the older people are, the worse they actually do. The longer you're seizing, the worse the potential outcome may be. Mortality by etiology in status, we see that anoxic brain injury probably has the highest. Even though this data was obtained many years ago, it is still felt to be true today. And of course, mortality, the longer people seize, the more likely they are to pass away from this disease entity. Additional information regarding mortality. Or even scores have been created to try to help predict which patients are not going to do well with status. Diagnosis is the key to early treatment and have a high index of suspicion. So if the onset is unknown and a convulsion is witnessed after the patient reaches medical attention, status epilepticus should be assumed unless consciousness is regained. So for those patients that are having events out of hospital, we know that lorazepam, 2 to 4 milligrams, or diazepam, 5 to 10 milligrams, is better than placebo and is shown to be effective. For certain kids, they can have cluster type seizures where they would have a flurry of events, followed by a period of calmness and another flurry of events. They can be treated with rectal diazepam, sublingual lorazepam, or buccal midazolam. In the first 10 minutes, we want to make sure they're protecting their airway. We turn the patient on their side. We don't try to put anything in their mouths. like you see on television. That doesn't really work. We try to obtain some history if possible. We want a certain amount of blood work to be performed, 2 intravenously placed, and the patient to be given thiamine, glucose, and the treatment of hypothermia. And we call for an EEG to be performed, but we don't delay in the treatment for that particular study. We just treat the patient. After the patient has been given first the benzodiazepine, we expect that to buy time to start something else, such as phenytoin or fosphenytoin or Keppra or levetiracetam or other agents. So the benzo is to buy you more times for that second agent. If that second agent does not work, they've reached the max dose of benzos, they've reached the max dose of Dilantin or whatever that second agent is going to be, and they continue to have events, we should then put them in iatrogenic coma. And phenobarb has been the one that has been discussed over the years the most. It's been around the longest, but we can also do it with midazolam or even propofol. When we place patients in iatrogenic comas, the goal is to put the brain to sleep, to kind of jumpstart the whole process and put it to sleep. So this is something we find very helpful. The evidence for burst suppression pattern on EEG is not strong evidence, but this is something that's still well recognized within the study of epilepsy. Just a schematic of some of the choices and some of the options that we have available to us. So if a patient were to be in an iatrogenic coma, when do we lighten them up to see if they're still seizing? Well, after 24 to 48 hours, we will lighten them up to see if they continue to have electrographic seizures. And if so, we put them back down. And if not, we continue to lighten up their drugs to get them out of the iatrogenic coma and to hopefully get them extubated. With management of prolonged seizures, sometimes people can be kept in iatrogenic coma for days, weeks, or even months. For non-convulsive status, we know that after a person has generalized convulsive status epilepticus, more than a third of these patients will have non-convulsive status. In neuro ICUs, it was published by Dr. Jordan that 34% of patients without overt seizures were having subclinical seizures, a third of the patients. So we should be very sensitive to this possibility and have a very low threshold for EEG monitoring to evaluate for possible subclinical seizures. We know that seizures are bad and status after stroke leads to a 3 times increase in mortality. The duration of the seizure and delay in diagnosis are independent predictors of outcome in non-convulsive status and convulsive status. The highest non-convulsive status is seen with acute brain injury plus seizures that can elevate neuronal specific enolase. How long should the patients be monitored? I think for those patients in the intensive care unit, the minimum time for monitoring is a 24-hour period of digital video EEG monitoring. 48 hours if they're comatose. Routine spot check or 20 minutes like we used to do years ago, we do not believe is an adequate in critically ill patients. Prognosis, you see here, heterogeneous. Why perform continuous video EEG monitoring in ICUs? Just because often subclinical seizures are intermittent. They help define the nature of the spell, including automatic automatisms. We can better prognosticate. And here is a schematic looking at the spectrum of seizures. So if we were to look at the bottom of the slide, interictal goes from interictal to ictal. And on the far left, it goes from low to high. GCSE is generalized convulsive status epilepticus. NCSE is non-convulsive status epilepticus. NCS is non-convulsive status. PLEDS, periodic lateralized epileptiform discharges. EPC, episodic periodic continuous events. SERPITS stands for stimulus-induced seizures. So overall summary, seizures in epilepsy have had a variety of causes and potential treatments. Acute symptomatic seizures are common in the ICU. Please have a low threshold for thinking about something like this. It's a very heterogeneous process, and the mortality is strongly related to the etiology and also how long it actually lasts. Digital continuous EEG monitoring is becoming the standard of care for critically ill patients. And a majority of the seizures in the intensive care unit are not detectable clinically. Subclinical seizures are common, especially in comatose patients. Please use the video portion and quantitative EEG tools, maximizing communication between nurses, techs, EEGers, and clinicians. Review. Overall, discuss issues of seizures and epilepsy, emphasizing on the inpatient setting. We looked at precipitants, treatment options, and protocols for status. Question number 1. What is the most important factor to predict poor outcomes and status? A, age. B, seizure duration. C, type of status epilepticus. D, symptomatic etiology. E, all of the above. The correct response is E, all of the above. Which is the etiology of seizures that cause the most mortality? A, anoxic brain injury. B, cerebral hemorrhage. C, tumor. D, infection. E, drug. The answer is A, anoxic brain injury causes the most amount of mortality. Question number 3. Which of these diagnoses can mimic seizures? A, cerebral ischemia. B, movement disorders. C, sleep disorders. D, psychiatric disturbances. E, all of the above. E, all of the above. What is the most important consideration for EEG monitoring in the ICU? A, defining the nature and spells, including automatic signs or automatisms. B, quantifying seizures. C, detecting hypoxic ischemic injury. D, prognostication. E, all of the above. And the correct response is all of the above. Question 5, what is the most important initial management of a seizure? Airway, ventilation, O2, paralytics, blood, glucose, electrolytes, AN, ABG, AD, tox screens. D, normal saline infusions. E, all of the above. The answer is A, protecting the airway. Most seizures only last for about a minute to a minute and a half.